Thank you so much for coming to this session. I have to tell you, personally, I feel incredibly lucky to have this session featured as a part of the Congress. In January 2021, there was a landmark publication by the Lancet Commission on the Value of Death, and a subsequent webinar on the topic, and really, more importantly, a tremendous amount of engagement and discussion globally about this important document. And we're so lucky to have two of its authors here today, including its senior author and one of the senior advisors on the Lancet Commission. And so I'm going to introduce them. But first, let me just say I'm going to draw from the executive summary of the Lancet Commission document, which says, "The story of dying in the 21st century is a story of paradox. While many people are overtreated in hospitals with families and communities relegated to the margins, still more remain undertreated, dying of preventable conditions and without access to basic pain relief. The unbalanced and contradictory picture of death and dying is the basis for this commission." And the commission proposes a new vision for death and dying with greater community involvement alongside health and social care services and increased bereavement support. So that's what is in some of the language you'll find in the document. I will say that for myself, one of the extraordinary innovations that I think is part of this document is an articulation of the idea about the systems of death and dying that we have in our various corners of the world. And I thought this was just a wonderful frame for us to think about how we care for people at or near the end of life, and also an emphasis on relationships, which I think is fundamental to our work. So allow me to introduce our speakers. Dr. Libby Sallnow is a palliative medicine consultant with the, oh dear, I don't know what CNWL stands for. CNHS, I knew that part. With the NHS in London, and an honorary senior lecturer at St. Christopher's Hospice and the UCL Marie Curie Palliative Care Research Department, also in the UK. She has helped lead and develop the fields of new public health approaches to end-of-life care, compassionate communities, and social approaches to death, dying, and loss over the past 2 decades in the UK and internationally. You don't look old enough to have done that, sorry. Really an extraordinary career already. Her PhD explored the translation of a model of compassionate communities from Kerala, India, to London in the UK. She's published over 25 articles and book chapters in these fields and co-edited the book International Perspectives on Public Health and Palliative Care in 2011. She is an honorary consultant at the World Health Organization Collaborating Center for Palliative Care in Kerala, India, Vice President of Public Health Palliative Care International, the President of the Palliative Care Section of the Royal Society of Medicine in the UK, a postdoctoral researcher at the Vrije Universiteit Brussels in Belgium, and the first author of the new Lancet Commission on the Value of Death, which we are discussing today. Dr. Roz Taylor is known very well to many in this audience. She's qualified as a doctor at Cambridge University in 1980. She initially worked as a GP in Cumbria, and in 1992 joined pioneers to establish a palliative care unit in West Cumbria Hospital and became enthused by the specialty, as she has written. In 1996, she took on her leadership role at the Hospice of St. Francis in Barkhamsted, Hertfordshire, a post she held until March 2015. She then became clinical director at Hospice UK, a national umbrella charity for the hospice movement, and has spent time since working at the bedside of patients at the Royal Marsden and Royal Brompton hospitals. Dr. Taylor now has over 26 years' experience in palliative care and was awarded an MBE for services to hospice care following a nomination by a St. Francis patient. She has recently contributed a chapter on spirituality through the lens of a doctor in a new book, Spirituality and Hospice Care, and she has contributed extensively to the new Lancet Commission on the Value of Death, as well as being a senior advisor and a very, very dear friend to and advocate for the McGill International Palliative Care Congress, for which we are all very grateful. Please join me in welcoming these two extraordinary people to the stage to talk about this wonderful and important work.
Thank you, everyone, and thank you, Justin, for that kind welcome to Ros and I. Our plan is to each talk for about 30 minutes, and I'll have some time for questions after mine, so we can break up so we're not listening to just an hour of talking. So do think about what questions, reflections, comments, the things we're going to discuss bring up for you, and do please come and offer them in between, and we'll hear from Ros and then have more time for questions after. So I'm going to talk about this new report, this new Commission report that came out earlier this year, which has the interesting title, The Value of Death. I have no conflicts of interest to declare, and the objectives that I hope we would begin to understand during the next half an hour and then the symposium as a whole would be to understand really what the impetus was. Why did this commission come about? Why this topic? To understand the diverse experiences of contemporary dying, and then to begin understanding the central vision for this work, the realistic utopia that I'll spend some time explaining. So the Lancet takes on often thorny, complex, wicked challenges, difficult questions that have no easy answer. And they've looked at a range of different topics, and they focused on the idea of death, dying, and care. And I will later distinguish between death, dying, care, and loss, but broadly, using the idea of death, it encompasses those different aspects. And it started with the premise, really the question or the challenge is, has dying become over-medicalised? And that was really the first challenge that was presented to us. So we began to look in more detail to understand what this challenge or what this assertion meant. So we know that death, dying, and grieving are universal concerns, and it always strikes me as surprising that they are not taken up as public health challenges, and they are one of the few issues that will affect every single person in a population multiple times in terms of often grieving and caring. But they are universal concerns, but often not treated as that. And how people are dying is changing, and we can see that over recent generations in high-income countries and increasingly in low- and middle-income countries. Some of these changes have been for the better. People are dying often later in life, not from preventable diseases that many people were dying from previously. And some have access to pain and other symptom control and palliative care as they die. But other changes have been for the worse. Other changes have elongated and prolonged dying, and I see in my profession as I visit patients at home, and I'm sure many of you will have the same experiences, people are often feeling unprepared when they come to meet these universal events. They feel unprepared with what the signs mean, how to respond, and the confidence of caring for people at these times. So we published this earlier this year, and we took a global perspective on understanding these challenges, understanding that there isn't just one answer to has death become, or has dying become over-medicalised. And we looked specifically beyond palliative care and beyond healthcare indeed. There was a palliative care commission published in 2017, which looked at the inequities, the challenges, and I'll talk about some of the outputs for that. But we wanted to build on that and then to go a step further, understanding that, as we know, palliative care does not own death, dying, and loss. We wanted to use, as Justin mentioned, a systems approach to go beyond the kind of often simplistic framing of A changing B equals C. And actually the complexity with which death, dying, and loss take place needs to be understood. And we considered structural issues such as gender, race, and power alongside religious and philosophical perspectives, consumerism, and economics. We started in 2018, and so were up in full swing, really, once the first wave of COVID-19 happened in March 2020. And we had a meeting at the time to reflect on the title. Is this something that people will be able to listen to and be able to hear and want to read when there was potentially so many deaths that were about to take place? But during that meeting, we reflected that actually these events, though traumatic and very distressing, make the recommendations of what we were doing even more important, that would allow us to be potentially more prepared for future emergencies and pandemics. And we wanted to go beyond rehashing, retracing the challenges of contemporary dying, caring and grieving, and to move beyond this to present a new vision, to be hopeful and intentional. And so that's what I will move on to at the end of this presentation. We started by considering what is it like to die, care and grieve in the 21st century, and what is shifting? So we looked at global mortality trends, pulled a lot of data together, and on the surface it's a success story. People are living later in life, people are not dying of conditions that previously would have been fatal on a global level, though there's obviously significant differences across and within countries. But if you look and scratch beneath the surface, there's disproportionate progress. So whereas global life expectancy trends are increasing, often, particularly during either eras of austerity or secondary to COVID-19 or other challenges, you can see reversing or stalling of life expectancy. And what we also see is that healthy life expectancy, so self-reported, years spent in self-reported good health, has not kept pace with life expectancy, simply the years lived. So people are living for longer, but in poorer health, and that is something that we are well used to, and there's a great deal of studies unpicking this. And there's been a shift we can see, and I'll present some data of the shift from communicable to non-communicable diseases happening globally. And we wanted to build on the concept of serious health-related suffering, which was first described in the Lancet Commission on Palliative Care and Access to Pain Relief. So this is one of the first tables from the Commission, and I've highlighted just a selection of different topics, different figures that illustrate just what's going on globally and why the idea of one story and one challenge is so misplaced. So here we've got a list of countries that were represented by commissioners on the Commission. So we had commissioners from the UK, from the US, Mexico, India, Bangladesh, Malawi. And here we can see that the global life expectancy has increased. A colleague, Luxon, and I, who are working on the Commission, our life expectancies in our countries between Malawi and the UK are separated by nearly 2 decades. And then if we look at some of the other figures around maternal mortality, deaths related to communicable, non-communicable diseases, and deaths, the associated serious health-related suffering, you can see there are stark polarizing differences across high, middle, and low-income countries. We then looked at where people are dying to understand what shifts are taking place within these global figures. And there's not a great deal of data, but one of the studies we pulled out demonstrates, and I think these figures have been picked up in a parallel session I was attending around the high rates of, for example, hospital death in Canada. And then looking at the increasing expenditure which we see towards the end of people's lives. And you would expect, if there was a steady expenditure in the last 6 months of life, for the figures to be broadly similar, about a sixth, so about 16%. And we see here there's an escalation in cost of treatment at the end of life. And there's some data that we looked at in the UK, which unpicks some of this to begin understanding what's the content of this increased spending that we see economically really across countries. And we can see that it's in unplanned, so accident and emergency, so ER, emergency room admissions and hospital treatments. It's not in outpatient, really, in GP, family physician meetings. So there's something that's really escalating in the last weeks of life when you look at population perspectives. And this is part of a much broader challenge. You know, the end of life brings a specific lens to understanding what's happening with this spending. It's hard to say from population studies what the value and the utility of this spending was. But what we understand from this, it's a great article published in 2017, which looks at overtreatment more broadly across healthcare. And whilst the definition of overtreatment depends hugely whether you're looking at a rational economic perspective or an individual person sitting in a hospital bed thinking about what their value would be. We can see, if you look broadly, there's a spectrum of treatment that is broadly going to increase net benefit, not increase net benefit, often cause harm, and then a very large grey area in between. And I think what we need to begin understanding when we looked at the global perspective, that actually there is a great deal of treatment that does not give utility, and, for example, chemotherapy in the last few days of life, inserting of feeding tubes, antibiotics for no indication and no sense of reversibility. We found a lot of evidence of overtreatment, which may explain something to do with these economic perspectives that we see. So we came to this idea of this central paradox. There's not one story with how people are dying. There's not one story of the end of life. And whilst some people may be having deaths that would be seen as over-medicalised with treatments they would not wish to have that are not increasing benefit for themselves and may increase suffering and prolong dying, still more people are hugely undertreated, both in terms of not accessing universal health coverage and preventative treatments for conditions that would otherwise be curable. But this picture up here on the left is from the Palliative Care Commission, the Lancet Palliative Care Commission, and demonstrates the amount of morphine that is available per person in need, so not per capita, but per patient who needs palliative care, how many milligrams of morphine is available to them. And here we see countries that are bloated more morphine than is needed, so particularly in North America, we see kind of 50, 60, 70,000 milligrams per person in need, whilst other entire continents are reduced to a simple line, a strip, there is no access. And obviously a poor proxy for the quality and skill around end-of-life care and palliative care, it is a very good indicator where there is no treatment and of undertreatment. So it isn't that death is over-medicalised and dying is over-medicalised. It is in fact a complex paradox where for many people death is over-medicalised and whilst for others it's seriously under-medicalised. And I see this both across, you can see this across countries, but I see this within my own practice in London on one side of the street to another. So, you know, it brings in together with it issues of access and equity. And we see this both within countries and between countries. So not an easy solution then to begin to find a way forward for this, which is where we came to begin to understand the complexity within which these universal human events are taking place. And a systems approach allows you to begin understanding the different levels and the different layers that we must understand and then begin to challenge if we are to achieve any sustainable change in how people are dying. So a systems approach really, I think for me, involves asking questions, being curious at each level of data or each response you get, and then continuing to ask, but why does that happen and why does that happen? So you might start, this iceberg model is a classic model for understanding the kind of layers of complexity. And so you start with an event, which, for example, the data that I showed you in the second table suggesting more people are now dying in hospital than they had previously. And so you then ask, what is happening? Why is this happening? So you go a kind of level deeper. And so you then begin looking at some of the patterns or some of the trends that give you an indication of how, where, and why this is happening. So if we look, we can see it's a progressive trend in many high-income countries and increasingly now in low- and middle-income countries of people dying in institutions versus being at home. And we also see that people are dying later in life and that there is an increased healthcare spending around these times. And these are some of the kind of other supporting ideas that you begin to look at when you ask, why does this happen? Then you go one level deeper to look at what are the underlying structures or forces that are creating this. And here we begin to look at so increasing life expectancy and the epidemiological transition, so switching from communicable diseases to non-communicable diseases. And the shift that then places very different models of care, people needing different healthcare interventions rather than a kind of acute care model. And people beginning to understand and think of healthcare as a solution to everything. And so this links with this broader professionalization that we see within society over, say, the past 100 years in many different high-income countries. And so this kind of professionalization leads people to seek cure and support in hospital as the kind of the first response. And then you go down to the mental models to understand what kind of cultural attitudes, paradigms, ideas inform this. And this is where we get to some of the really interesting ideas around, is death infinitely deferrable? Will there always be one more treatment that is available? And can you increasingly see how people are feeling that value and love is expressed within families or within communities through the medium of healthcare. And we saw a lot of stories, particularly from our colleague, Dr. Rajagopal in India, who was saying he increasingly saw value of life as being really given and ascribed in how much treatment you could have and how much medical intervention you can have. So these real difficult challenges around sense of immortality, you know, the next cure, and these are perpetuated by front pages of newspapers that there will be a cure for dementia, a cure for cancer, this kind of elusive sense of us trying to achieve this. All of this then informs the very discussions that then happen in an outpatient clinic that would lead to someone then dying in hospital back at the tip of the iceberg. This is a picture from our Lancet Commission, not intended to be used in a kind of day-to-day sense, but an image to illustrate the complexity of what happens around someone dying at home. And this is just an image. It's a causal loop diagram, so there's positive and negative feedback loops to demonstrate what is happening, the complexity of what goes on when someone is dying at home. And for me, it really illustrates our naivety to think that simply starting a new service here, you know, will then lead to less people dying in hospital or more people dying in where they would like to be or more people accessing pain relief at the end of life, equaling better outcomes. You know, we must understand the complexity within which any interventions we are trying to start, that kind of complex web within which they exist and interact in unanticipated, emergent and different ways. So we wanted to bring this diagram, this systems map, so to really illustrate and remind us this complex web that within which we are all acting. And actually we take part in systems in all of our lives, you know, education systems, financial systems, hospitals are systems, families are systems. And we're somehow used to understanding this unpredictable, unanticipated consequences, integrating multiple inputs to understand things, whereas somehow there's a kind of allure of a kind of reductionist, a simplistic thinking of actually, no, but there's some easy solutions. We can do this, it will equal that, and it will always equal that outcome. And actually, we really need to begin bringing much more of our complex systems understanding if we want to really sustainably shift experiences. So that brings me on to this idea of a realistic utopia. And here we had took the idea from a US philosopher, John Rawls, to bring this radical imagining of a new future, but one that is achievable. So this is not a utopian kind of blue sky thinking. This is about using our collective imagination to think, where would we want to be? What would it look like if people were dying, grieving, and caring well? And if we understand what that would look like, how then could we create steps to get towards this idea of a realistic utopia? It's both radical but achievable. And it's based on principles that people can share. So we came up with 5 principles across the Commission, and we wanted to allow these to be sufficiently high level that they could be understood, interpreted, pulled apart, and used locally, regionally, nationally, as well as speak to a global community. So they're high level, but they are meant to be interpreted and then used to push local and national change. So I'm going to run through the 5 principles now. The first is we need to acknowledge, understand, and then address the social and structural determinants of death, dying, and grieving. And here this image that we've chosen is of the interconnected nature of dying, living, and grieving. Now, the social and structural determinants of health is something now that really has come into our language, our understanding, our ability to see that health is not created through healthcare services. It is created by a complex web of our social, structural, environmental, economic, educational determinants, and they influence our well-being, our health, our ability to make decisions and live different parts of our lives. And that's something that's quite well established. The WHO Social Determinants of Health Commission back in 2008, has really opened up this field. But we seem to have forgotten that how people live, the social determinants that have determined their well-being, their health, their choices and their outcomes directly influences the experiences of dying, and how people then are able to either make decisions, have agency to change their lives and make decisions. And for me, the idea of choice at the end of life is very difficult to actually see. But if you've not had choice in the rest of your life and during other health outcomes, why now is choice something that will be available to you at the end of life? And so we need to understand how people are dying is determined by their broader environmental where they live, the family networks, their access to healthcare, their trust in healthcare services. All of these things have just as big an impact. And of course, how you die and the situation or context of that affects the grief of those around you. And so then the social and structural determinants of grieving are influenced by the dying, but then go on to influence how those people go on to live their lives. And there's a huge literature to explain and understand the likelihood of going back into employment, returning back to school. The kind of physical and social effects of grief can be really significant and very different depending on how people are supported or able to make sense of that grief. It's all connected. And what we really try to say is we need to begin thinking about death, dying, grieving as part of living and as subject to the same social and structural determinants that health and well-being are. So a good example of how this has been integrated is through the project in Bangladesh in one of the largest slums, Koral slum, and there was a plan to start a palliative care project out there. People were dying with no support and often in pain. And so there was the initiative to initiate this. But of course, this is an incredibly marginalised community with no access to formal electricity, water, healthcare services. So actually starting a palliative care service in the absence of any basic healthcare was just not seen as appropriate for the residents. So there was a sense of how do we begin to address some of these broader social structural determinants and situate palliative care that is responsive to that, and also begins to tackle some of those broader social determinants such that people aren't dying young, unavoidable deaths that could otherwise be treated. You don't want to be giving them palliative care. Ideally, you get to the root. So it's how palliative care sits with those broader and social structural determinants. The next is that dying is understood to be a relational and spiritual process rather than simply a physiological event. Now, I'm talking in here, I think, to the converted, and that's something that is not radical for us, but we were mindful of the audience of this. We wanted this to be a broad audience. We wanted the readership to be broad through the Lancet, and actually this, I don't think, is something that people are taking on board, and it was mentioned in the opening lecture on Monday night by Justin around the focus of relationships and just how central they are. And we are forgetting that, and this is being forgotten throughout hospitals, and I think even in some palliative care services, as there's a risk to become transactional, the kind of tick box of achieving all the things we need around end-of-life medication, mattresses, the right care package, etc. I speak from my own experience. And actually we're forgetting that all of that is just a platform on which relationships can then develop, meaning connection, those broader existential challenges can be tackled, understood and taken. That's the work of dying and grieving, and that's really the work of palliative care service to support that. And this is an example of, in London, Compassionate Communities movement, which focuses on building the relational, the kind of that next step, right? You've got the bed, pain is managed, symptoms are controlled, what's next? And this is about then how do you create, nurture, foster relationships around end-of-life issues, around grieving, caring. And in Canada, you have a huge wealth of these, a really well-established compassionate communities movement, and it's increasingly growing around the world. And this is really one answer to how can we support the relational aspects of death, dying, and grieving. The next is around networks of care. And we talk a lot about integrated care, and this includes the need to have integrated health, social, oncology, palliative care, primary, secondary care, etc. So integrating, obviously, across professional and settings, but so much more than that. This is around integrating diverse networks, including lay, family, community, oncology, primary, secondary care, etc. And really understanding that people are not going to be able to die or grieve well just because they have one great doctor, one great family carer. It takes a much broader network. And what we're not good at is understanding how we begin talking across these networks. There's been a lot of work on integration through professional networks, but this questions us and pushes us to take a step further to understand, as professionals, we must be understanding, exploring, mapping, finding out who is in these networks, and within families, having much broader connections within community networks, and drawing on these different resources, because that is where you begin to mobilize resource, understanding and connection and learning around these events. This picture is from a study by some colleagues in Australia at the end of life, dying at home, co-creating an ecology of care. Really interesting project which took an appreciative approach to understand when people have died well at home, what happened, and they worked back. They did social network analysis, mapping carers with those around them and the broader networks. And here we can see inside is the carer, one of the red people, with all the family and community networks around. And out on a limb are the palliative care nurse, palliative care doctor, family physician. And I think that's a really helpful wake-up call to us. Where are we situated in these links? Often we think we are in the centre, but actually often we are seen as peripheral. We may come in and out, but we are not having conversations with these broader networks. And often they're difficult. They're around power, language, risk, respect. But actually one of the challenges that we ask through this commission report is that we understand where people, who is involved in these networks, where our role is within it, and question how we begin to have more of a conversation, or at least to not disempower these networks is the first step, and then to think about how we can begin having conversations. We reviewed a lot of strategies, national, international strategies, on aging, on COVID, on various life-limiting conditions such as liver disease, etc. And really interestingly, death and dying is not mentioned. It's often mentioned under a subsection where palliative care is mentioned under something else, and death and dying are mentioned as a subsection of palliative care. You know, these are, again, universal events that should be being recognised by policy strategies on health, and particularly on ideas of aging. So this is from the social determinants of health literature, and one of their models for understanding how, through the life course approach, we should be looking at prevention, improving access to a range of different determinants of health. But really interestingly, you just retire, nothing else happens after that. I find it so shocking. We've asked Michael Marmot, who's one of the key thinkers in this, and he really agrees this is an oversight. Actually, death, dying and loss, it comes back to that first interconnected cycle. They are a part of health and well-being. It can be healthy to die, and it is certainly healthy to grieve. And we need to begin incorporating that, understanding the huge impact that poorly managed grief, bereavement, dying has on all of these other life course stages. So we really call for strategies, for guidelines, for national and international goals to recognise death, dying and care and grieving as part of health and well-being. And they must be mentioned. If there is no space for these to be mentioned, no space for them to be discussed, then we will not have people able to then begin to respond from it and to begin to think that actually death is a normal part of life. And I'll come more onto that. And it's not just strategies, governments, healthcare authorities that need to be thinking about this. It's also ensuring that there's space and language and narrative within communities to understand this. And often people talk around, the idea of people must talk more about death and dying, and there's no should with this. This is people need to make their own decisions. But there is a sense of this new concept of death literacy, and a sense of people wanting to have the skills and wanting to know what to do, but not knowing where to access these skills. And often they may have been present in people in communities who were experienced, who would care for those dying, and there's a sense that's been lost. And so the Death Literacy Index has been initiated by, again, the same team in Australia, which is a series of 4 different domains around experiential learning, skills and action, which suggests what skills people have got in communities that would allow people to die well at home. Do people know how to access support? Do people know how to care for someone as they enter in the last days of life? Do people know how to access and support someone who's grieving? So a really interesting way, again, of this kind of parallel idea of becoming death literate from guidelines, international guidelines, right through down to community knowledge and discussion that happens on streets. And the final principle is that death is recognised as having value. And I think this is certainly our most kind of abstract concept and the hardest one to articulate in a kind of practical sense. But it comes down to death being recognised as a part of life. And it is not always welcome, it's upsetting, loss is hard, it's difficult. But it is an inescapable part of our human condition. And so we say that by hiding this, denying this, we devalue death. And when we assert then that this devaluing of death is one of the fundamental drivers really for overtreatment, for this quest for immortality, for this idea of beating death, and a denial of this time in people's lives really prevents there being a space for people to understand it. And this goes beyond this goes beyond just provision of services. This is creating space where death, although distressing and upsetting, dying, has a place in society. And by not talking about it and not creating even policy recognition, yet alone those broader societal recognition, it creates more problems by hiding it. So we need to acknowledge and value the part that death plays in all our lives and in society, actually, in our lives as humans. So the last couple of slides, I'm just going to talk about more practical examples. So there are examples of the realistic utopia around the world already. We are not reinventing things. We are not starting something here that has not already got strong roots globally. And I've given some examples as I've gone through the 5 principles. But what isn't happening is a kind of concerted sense. This is not available to everyone around the world. And we are really trying to understand how could these 5 principles be interpreted and put in place throughout the world. This is probably my favourite table in the whole report, which looks at the leverage point, so getting into a bit of systems thinking, which is how you begin to shift systems. And the most powerful way is to shift the mindset or the paradigm of a system, and goes all the way down to how you change rules, how you begin to shift the goals of a system. And so we imagine in the second column, what would it take to shift the systems that we are all acting in, whether we are aware of them or not, whether they're explicit or implicit. How do we begin to shift them, subtly or radically? And then in the final column, it gives examples of where this is happening already, where these examples already exist. And it's a question of learning, sharing, spreading, translating these ideas. And the last slide, I will just talk through some of the key messages. So we have these at the beginning of the report. So dying in the 21st century is a paradox. People are both overtreated and undertreated, often simultaneously in the same person, but certainly we see this across countries and within countries. And we see how then, as a result, death, dying, grieving have become unbalanced. There's a sense that the medical part has often become too prominent or less prominent, but that there's a sense of how the community, family are involved has shifted, and that is leading to something that is unbalanced. We make some very clear links to the climate crisis, this idea that our delusion that we are in control of death, we will somehow beat death, is similar to our control of nature in the sense that we actually can manage nature rather than being a part of nature, and therefore death and dying being part of our lives. Rebalancing death and dying requires radical changes across death systems. The disadvantaged and powerless suffer most from the current imbalance in death systems, and if we are to meet the urgent challenge of inequity in access to palliative care service, inequity in access to pain relief, and inequity in experience at the end of life, then we need to use systems approaches. These are not simple, quick fix solutions whereby a new service opening at different times will meet this. This requires a systems approach. The 5 principles of the realistic utopia presents a new vision of how death and dying could be. And the challenge of transforming how this happens has already been responded to by many people and many services and settings around the world. And that inspiration is there. And then finally, radical change across death systems is urgent and is a collective responsibility of which palliative care has a huge part, but not the sole part to play. So death and dying must be recognised as not only normal, but valuable, and care of the dying and grieving must be rebalanced. And there's a QR code there to download the report. It's obviously free access. Many thanks. So if anyone has any questions, I can't see actually, do come up to the microphone or comments. Fliss. Yes, just shout.
What would you like to see as the next steps for this to become reality?
It's a great question. Well, our first aim was to get this out there. So this first year is really looking at how we promote it, share this vision. And the next step is to come together collectively. And we're going to need some funding, we're going to need some consensus, and I think some buy-in from people outside of palliative care. That is what I would like. This message, we're the right people to be hearing it here, but actually we have to take it out more broadly. So I would like this message to be picked up by both people, our colleagues in the broader healthcare service, but more crucially outside of that, within government, within society, because that's where the real change. And if we're looking at a systems approach, we are one part, one cog really within that. And the question is, how can we take this message more broadly, and what part can we all play in sharing that message? Yes.
My name's Nicky Quinlan. I'm a doctor in California. And you talked about the value of death. And could you just go into that a bit more? Obviously, sometimes, what came to mind was one of my mentors in Boston said something once which was very profound. She said, "This patient needs to die." And it's haunted me ever since, because it comes up that some patients need to die to release themselves and their families and everyone else from the hard end that they're facing. And so anyway, I don't know if that's the value of death you're getting at, but obviously it's much bigger than that. But there's just this profound release that death brings, and I think sometimes it's a very good thing. That's all.
Thank you. Yeah, and what we tried to do is to understand that, death is often seen as the kind of a failure, as an endpoint that must be avoided at all costs. And actually, that narrative is hugely dangerous and undermining, because of course there are times that death, we really focus, that's the paradox, that actually we push back against avoidable deaths, and we must do all we can to promote universal health coverage, to access to treatment. That we're not promoting the idea that death is good in all its sense, but death is an integral part of life. And so there is value in that kind of bookending of birth to death. And by devaluing death and saying it has no place, it is the enemy, we will be beating it at all costs, then we devalue actually part of ourselves. And we talk a lot about the gift of death, and this is not to say that it's always a good time, but there can be times when actually being with someone who's dying gives a sense of our shared vulnerability, our commonality, our fragility, and actually that is something that we need to be reminded of. And that's where we begin looking at some of the common links with climate change, this idea that we can beat all of this and we're bigger than this. Actually, it's part of our lives, and we have been pushing back so much on that actually we're asking for us to bring that back into life. There are times death must be fought, and there is reversibility, and then that's important. But there are other times that death is a natural part of life, and it can be healthy to die. And so we really posit that around, what does a healthy death look like? When is the time right?
Thank you. Here's a question that comes from one of our viewers on the stream. His name is Gregorio Zuniga Villanueva, and the question is, a previous session debated the branding of palliative care and how we strive to move away from the end-of-life only label. What is your insight for those teams, countries, where acute death is so high that they can only see end-of-life?
So I was really thinking during that, the plenary, I really enjoyed thinking, what does our branding mean? And the kind of move away from using death and dying into using supportive care. And my team in the hospital that I work in the UK has been rebranded as palliative and supportive care, and it has increased referrals. But there's something about colluding with this devaluing of death, which I find very problematic. And I think there are times, we don't want to be talking about death from day one, and it is frightening, it's distressing, it's hugely upsetting, and loss will always elicit that response. It's a human response, but I do think that we do need to acknowledge that we are caring for people who are dying, and actually that is a natural part of having a serious life-limiting illness, and that by somehow hiding that through layers of terminology, we're actually colluding, and essentially it will make it harder when those realities come through. So I think it's about how we ensure we're maximizing access, and when the time is right for people to have that discussion. But it also needs to be not just happening within palliative care. I think it's almost too late then. The narratives that are played out in the palliative care consultation, in the oncology consultation, in the intensive care unit, are part of the broader narratives that are being played out in society. And it's only by us actually understanding those broader narratives and beginning to shift them within which palliative care, that's not within our gift, we can't do that alone. Until we shift those broader narratives, that broader system, then we will not change what's happening with people not wishing to talk about it and finding it hugely surprising and a huge shock when actually they understand that this is care at the end of life. So I think the branding, we're only part of that much bigger system and that much bigger societal discourse that needs to shift.
Thank you. My name's Jenny Phillip from Melbourne, Australia, and I guess my point follows on very much from that. A few weeks ago I was at a lung multidisciplinary or tumour board meeting for lung cancer, and I'm the palliative care person there. And there was a big debate about a person who was in their, I think, early 70s, who had a mesothelioma and very extensive disease, and there was a possibility that it could have been surgically resectable, but pretty unlikely. And I sort of bravely put up, after a fair bit of discussion, I bravely put up my hand or my voice and said, so what chance do you think we have of curing this? And the surgeon said, oh, very low. And the whole sort of notion of trying to put forward that perhaps no surgery was a good alternative, which I sort of tried to do in a fairly inarticulate way, that giving this person some space and having their dying. And then the surgeon, good fellow, but he said, but you've got to die trying. So it's sort of interesting. We really need to have...
Wow.
It's very hard to articulate the value of death
Yes.
in that sort of meeting, I guess.
Exactly.
Thank you.
And I guess, we really thought, as I mentioned, about this idea, the value of death, and whether that's the right term, because it's quite a provocative title, actually, or concept. But I guess the idea of it can be healthy to die or natural, a part of that life. And that's, we somehow are deluded within healthcare settings, but also more broadly, that actually it can be inevitably pushed back, and we do have that within our power. And actually what we need to realise is that is not within our power, but somehow that whole kind of hubris really that happens in hospitals, that we don't then allow ourselves to understand the reality of what's happening. And palliative care often gives that kind of reality or dose of reality. But I think it needs to come from outside of us. We cannot be the only people delivering that. I think we might need to stop now, but we will have time for questions
still
after.
One question
Okay.
from someone who was accessing the session virtually. Her name is Anina Seller. And the question is, culture is becoming increasingly important in relation to end-of-life care in a context of globalization, migration, and integration. There are cultures which don't talk about diagnosis, prognosis, and end of life. Example, the movie The Farewell. How to deal with this?
So I think I would really kind of push back. I've thought a lot about this around the idea that we must all talk about death and dying. And obviously that's not something we can force different people, different cultural perspectives on what that means. But what we must do is create spaces where people, in their own way, using the specific terms or language that resonates with them, that there are spaces for it to be spoken about and seen. I think one of the challenges is that it's very difficult to talk about things that you don't see. And so often death is now hidden away in hospitals or in care homes. Often people don't see someone who's dying until much later in their lives, if ever, or provide hands-on care. And when they do then come across this, often it's a huge shock. They've got no sense of a script or a narrative of knowing how to manage this. So I think rather than forcing or pushing people to talk about these quite abstract concepts that are obviously distressing and elicit responses to our own previous experience of bereavement and loss, actually we need to create spaces where people see how death and dying and grieving happens. You can experience it, and that's what the Death Literacy Index looks at. How do people experience this practically? How do people really understand this tangibly? And that's, we often engage in an emotional sense with this rather than a rational sense. And that's where I think we would then begin shifting some of the broader cultural attitudes. I agree with that, with the question just made, but we don't have the ability to do that through just a campaign. We need to engage much more sensitively with different ways of understanding these. I'm going to hand over now because we need to hear from Ros Taylor, so many thanks.
Thank you. I just want to begin with 3 key messages. Firstly, we are very grateful from the Lancet Commission to be invited to present our work, and I just want to say I've been to 9 of the palliative care congresses in Montreal, and it's hugely influenced my learning and practice over the last 20 years. I've heard Eric Cassell talk here, Michael Carney, Harvey Chochinov, Bernard Lapointe, and Bal Mount, and many others. And I think we're so lucky to be here this time, and I look forward again to 2024. I also wanted to say that most of my heroes, or usually our heroes, are older than us, but actually Libby, who you've just heard, is much younger than me, and she is a great hero and a future very important voice. So you're very lucky to have heard her today. And thirdly, another hero who is older, and he's actually dead, but he's very close to Montreal, is Leonard Cohen. And he usually has a louder voice at this conference, but I've used many of his quotes and his music in my teaching. So I'm going to start and finish with 2 different lines. I'm going to start with, we find ourselves on different sides of a line nobody drew. So I think what the Commission is hoping is that we all end up on the same side. So I'm just going to spend the next half an hour going into slightly more detail on one of the social determinants of dying. Let's see if I can work this. No conflict of interest, and we've already talked about the objectives. So the lost words of dying, what I'm finding more and more in dialogue, that we have stopped using the word suffering. I know it's appeared a lot in this conference, and right at the beginning, Dr. Sanders in his public lecture said maybe we should talk a bit less about suffering and more about healing, and I absolutely agree. People don't people don't die in the UK anymore, they pass. I don't know where they pass to. We don't talk about vigil very much, that essential time right at the end of life. We don't talk about consolation. I've experienced a lot of consolation in the last 18 months of my life, and we talk less and less about presence, and it's so difficult to be present now in our chaotic healthcare systems. And just to go back to one of the questions put to Libby, well, actually I'll move on and I'll mention this is a real picture of a bookstore at a big London rail station, How Not to Die. I didn't buy this book, but many people did. And it reminds me of the shock, horror, when Queen Elizabeth died a few weeks ago. We don't know whether the meeting with our now ex-Prime Minister had anything to do with her death, but people were genuinely shocked that a lady of 97 might die. It just wasn't on anybody's agenda. There was a plan, certainly an advanced care plan of what to do, and we are very pleased that she wasn't flown to the local hospital, which was actually 50 miles from where she was. But that did seem shocking. So this is another great table from the Commission. You can't read the detail, but I've highlighted just one. Can I read the detail? Each column, it's the work of an author called Laughland, and it was written quite some time ago, 1980s maybe, or earlier, where she was looking at what had changed in relation to death and dying before 1950, more recently, and now currently. And she looked at doctors' involvements in death, which used to be low and is now very high. She looked at familiarity with death, which used to be high and is now very low. We've heard throughout this conference that medicine is doing too much for many people. And I came up with this term, event-centred care, because that's what I see daily in our local hospitals, where somebody goes in with an acute exacerbation of a long-term condition, and it's fixed with antibiotics and nebulizers and everything else and fluids, but nobody takes account of the trajectory of what has gone on before and what might happen next. And that conversation is not held with the family. And a junior doctor told me recently that they actually feel anxious if a relative comes towards them to discuss the future. They don't have time for those discussions anymore. But I also heard a great phrase earlier in the conference this week, which was called SOD medicine. Is anybody else in the lecture? And SOD medicine is single organ doctor-centered care. And that's what we need to move away from. Okay, I'm going to whiz on. So palliative care traditionally is about working with people who are facing suffering in all the different dimensions we know and living with uncertainty. And Libby has eloquently talked about the realistic utopia, and I'm going to talk about just one of the social determinants, and that is gender. Now, normally, and I've given this talk before on gender, and when I look around the room in the UK, it's usually 95% female, but I think we have a bit more balance here. So gender, I'm going to look at who cares for you when you're dying, the experience of care and how it's affected by gender, where you die and how that's affected, and the choices that people make. So I think most people would accept that the majority of our formal and informal caregivers, certainly towards the end of life, are dominated by the female gender. I want to really acknowledge a very important paper that, if you're interested in this topic, by Merin Gott. She really summarizes much of what I'm going to say, and which is also detailed in the Commission. So there are some startling statistics that I'm going to quickly run through. So in the States, 36% of doctors are female. In Japan, only 22%. And if you look at nurses, 91% of nurses are female in America, and in Japan, 97%. So there is this enormous disparity in potential for discrimination on both sides. So many of the male patients I've met have wanted male nurses and male carers, and they're nowhere to be seen. So power was discussed a lot during the debates we had during the development of the Commission. And power plays out in healthcare enormously. I mean, this is not a joke slide. This is a photo I took, and I'm not going to tell you where it was taken. You have to guess the country. It's definitely not the UK, although when I was training, we did have a doctor's dining room, but no more. But that power play plays out in healthcare. The hierarchical difference, and I know there's probably a lot of nurses in the room, between doctors and nurses and social workers and art therapists and counsellors and chaplains, I see that hierarchy every day in our interdisciplinary discussions. Where I work, the doctors lead the multidisciplinary team meetings. It's probably not essential. When I did some brief work in Calcutta, the family social worker led the ward rounds, and that led to completely different conversations. So what about value for these carers? The average care worker in London, I don't know how this translates into Canadian dollars, but £10 an hour and nearly 50% less than what a garbage worker is paid. Now, we value our garbage workers, but we need to value our care workers more. And of course, we know that, again, 95% of our care workers, certainly in the UK, are female. And what about informal family caregivers? Again, in America, 75% of all family caregivers. I think this is a difficult statistic because many people in families don't identify themselves as a caregiver. They are a wife or a daughter or a sister. So these numbers, take them with a pinch of salt, but we know that it is predominantly women who give up careers to care. And it's higher in other parts of the world. And it's everywhere. And just to say, how do our governments value this informal care, predominantly by women? So in the UK, if you are not working or working a limited number of hours, you can get something called the carer's allowance, which is £62 a week. So at £10 an hour, you're being paid for 6 hours of care when you're probably doing over 100 hours of care. So that's where care is devalued. And by devaluing care, we are devaluing dying and death. And people, of course, economists, have tried to really work out the value of informal care. And it's billions. I heard in one of the lectures earlier this week that informal care has been valued as over £100 billion in Canada. These figures are probably actually quite old, 470 billion in the US. So this is a huge expense, and it's probably an appropriate expense, but this care needs to be valued and funded so that people's economic lives aren't decimated by caring. And this quote really sums it up. The success of the global economy rests on women's unpaid work. We know that during COVID, it got even worse. 55% of unpaid carers feel overwhelmed. And I remember doing a survey with a group of carers. We were running carers groups. Actually, this was an online carers group during COVID. And I got them to do a questionnaire, and they all looked pretty resilient. And they were able to come online and talk about the challenges of caring. But when I gave them the questionnaire, actually it was a questionnaire that came from Canada, looking at the burden of caring, they all rated themselves at the end of their tether. So you can't see the burden of caring, and we need to ask people and assess more. So if I move on to gender and the experience of care, and I learnt quite a lot from researching this. My sister is a kidney doctor, a nephrologist, and she said even in her academic practice in London, she has seen and counted that women with end-stage renal disease are offered less dialysis than men. And globally, that statistic has been confirmed in this paper up on the screen. This is even more shocking, the next one, but there may be reasons. Maybe we're tougher, I don't know. But somebody researched how long women have to wait for pain relief in an emergency department when they arrive with acute abdominal pain, and women have to wait about 20 minutes more than men, or maybe 19 minutes. But why are there these discrepancies? There are assumptions about the resilience of women, or is it just sexist discrimination? I don't know. And where do people die? We know that home death, certainly in the UK and in many Western countries, is still used as a proxy marker of a quality ending. But home is often a very difficult place for many of the people that I meet. More women die in care homes. And care homes have a reputation. They are not a choice for many people to die in, or to live their final years in, or even their final months. The average length of stay in a UK care home now is about 18 months, and many are staffed by carers who are poorly paid, who are invisible, and we know what happened to care homes in our countries during COVID. And we're wondering whether this is ageism or sexism. And care choices towards the end of life. Women are less likely to choose life-extending treatment, and that's probably a double-edged statement. Is that because we have an increased sense of burden? And men are more likely to choose aggressive life-prolonging treatment, which is probably not great for them either. But we also heard in another lecture this week that that's definitely the case. More men die in ICU, more men die having had chemotherapy in the last 30 days of life. So what's interesting is these differences. And lastly, to talk about poverty. There's a shocking statement at the bottom of this slide. In India, 60% of women have no assets in their name. And most of the poor people in the world are women. That's from The Guardian, so I don't know whether that's an accurate statistic, but it sort of feels right. And this is a quote, and I'm really sorry I haven't got the reference, but it really, really moved me. My home is not a nice place to live, let alone a nice place to die. And yet we make these romantic assumptions that everybody wants to die in their own home and in their own bed. And even in my I work in a diverse part of northwest London, but it's relatively affluent in most of the catchment area, but there are still homes and social situations which really, really are not conducive to a good dying phase. So trying to unravel why there are these gender discrepancies is really difficult, and it obviously is a mixture of duty, of biology, of social constructs, but what's important is that they're recognized and that we try to rebalance. Because the impact on women, and it's been made worse during COVID, is huge. The fact that many women's careers are disrupted by making very wise, compassionate choices to care, but there should be more financial recompense. And there should be opportunities to get back on a career ladder. And there should be more care for our informal caregivers. And there should be more parity for nurses who are at the heart of palliative care. And if you get the chance to, I think it was recorded, listen to Professor Heather Richardson's lecture on the future of palliative nursing, or the future of nursing, the Lantern model being developed at St Christopher's Hospice in London, do have a listen. So the impact on the death system is that because of our devaluing, probably, of female care towards the end of life and probably throughout healthcare, are we relegating care and delegating care? And it is a fact that as social mobility increases, we delegate the care of the most vulnerable in our society, maybe our young children and our elders, to poorly paid, low-status care. So this was just really to emphasize that there is an urgent need to attend to gender as one of the social determinants of dying. And to rebalance that power, there are some recommendations. I don't know if I can read them because I've put them in a very funny background here. But, and I've already mentioned, we need things like a frailty fund or grant towards the end of life for the last year, just in the same way as we have got maternity leave. But if somebody is giving up their job to work, we need a better giving up their job to care, we need a better carer's allowance that is worth more than 6 hours a week. We need research to look at gender. Much of the research on opioids has been done on fit men. So when we're looking at opioid conversions, they're possibly not relevant to older women. I'm just looking for a light here. But I think the recommendations, they're all possible, and they're certainly all possible in our Western affluent countries. So just in the last few minutes, I want to mention, and I think Libby's already mentioned some of the ideas I'm going to share on some of the other realistic utopian ideas. So networks of care. We know that people are anxious about dying, and I remember hearing Professor Sheldon Solomon speak at this conference on death anxiety, and he shared with us, this is his book if you want to read it, The Worm at the Core, but he shared with us that following all his research, social philosophical research, the way that we manage death anxiety is to focus on people's self-esteem, but to also promote connection, the healing connection that Dr. Sanders talked about in his initial lecture. And we've also learnt that if people are better connected, they stay healthier for longer. I mean, it's a remarkable, it's not surprising, but it's remarkable that it can be proven that the quality of our relationships is linked to morbidity and mortality. Libby's already mentioned the disparity between our social networks, which are perhaps the most important in our lives, and our professional networks, and we need to unite them. So in our healthcare systems, we absolutely need to discover from our patients, from the people we're caring with, who is important to them. We've become better at asking what is important, but we often don't ask who is important. And this is a question that should be a routine part of our assessment. What would it take to support you to be cared for at home, and what can your family and friends bring to that? And it is a question that we ask. Libby's already shown this marvellous system map from Australia. But just to say, there are 8,760 hours in a year. And even if you have really good healthcare, you're probably only going to get 100, maybe 200 hours of healthcare, which means for 8,500 hours, our families, those living with serious illness, are on their own. So what do we do to inform, to coach, to support? And that's where the public health approach to palliative care comes in, because a lot of this is about peer support, social support, but also some knowledge and information. So it was good to hear about the Waiting Room Revolution podcast, which I'll listen to on the flight home to London. We need some more ideas to get into the hearts and minds of the public and encourage that peer support. I don't think this carer has been taught how to help his brother out of the chair. And I remember people being discharged from our palliative care unit without being taught the absolute essentials, because to some families this does not come naturally, to many it does. And to those families where there have been amazing long episodes of care, we would like to encourage that experience to be shared with other families so that we develop peer coaches. So we know that death or dying brings family or brings dynamics into focus, but it also is an opportunity, and we see extraordinary resilience and capacity to care in families, but we know that it can be worn out very quickly. So Libby has mentioned several examples of public health approach. She's mentioned Compassionate Neighbours, which is a great initiative now around the UK. And this is just, I think it's from your PhD, Libby, looking at what happens in the public health approach, how compassionate communities are initiated and what sustains them, and the fact that reciprocity is so important. But I urge you to read some of Libby's published articles. So it's back to power, and I just want to give an example, a very simple example, a small project I was involved with, and I probably still continue to do this. How many people in this room use WhatsApp to communicate with people? Yeah, that's everybody. So do you use it with your people you're looking after? No. Okay, I'm not sure why not. Something to do with confidentiality. But it is about power. Why don't we have groups? So this was a project where if somebody was going home with a very complex condition, this is about Harry. He had a daughter in Dubai, a daughter in Australia. They all wanted to stay connected, and they wanted to stay connected to the doctor and the nurse who knew Harry best. So we set up a group, and it made a massive difference to Harry in his final weeks. Nothing was breached. It was all done with consent, and it just meant that there were no expectations to answer messages in the middle of the night, but there were a lot of messages in the day, and the family were so reassured by having this immediate connection. And it's not difficult. So, WhatsApp groups. And I think we do have a hesitation to be brave. Dr. Kieran Sweeney was a UK physician who died of mesothelioma, the asbestos-related tumour, and he felt that his doctors weren't honest with him about prognosis, and he this hesitation to be brave is a comment that stuck with me. I'm going to move on quickly because we've only got a couple of minutes. So we've talked a lot about healing connections. I urge you to read this paper by Bal Mount, which was an eye-opener from me. And the next slide is some of the recommendations that we've already talked about. There are recommendations in the Commission for different audiences, for our public, for our healthcare professionals, for our governments, and we've tried to structure it in a realistic way. And lastly, just for the last 2 minutes, I just want to mention stories. I've mentioned the story of the Queen. I also want to mention the story of my daughter and to bring her to this conference. She died 18 months ago. She took her own life during COVID, and it's obviously been a very difficult time for me, but it's been a very healing time coming to this conference and meeting old friends again. But why I'm telling you her story is that I used Twitter a lot to keep some of the messages she taught me alive, and I was just about to stop tweeting about Phoebe when I got this message in a private message, and I'll read it to you. Hi Ros, it was from a doctor in fact. Hi Ros, you don't know me, but I just wanted to, I'm just trying to read this, say you've had a huge impact on my life, and I'm sure the same of others. Your story and your openness about Phoebe made me not carry on with my suicide attempt. I hope this message doesn't cause any upset. I just felt you needed to know the huge impact your tweets have. And that was a very goosebump message to get. But I guess it showed me the power of sharing stories, however hard that is. And we have to share the good stories and the bad stories in order to learn. So just to finish off. And I just want to finish with another Leonard Cohen quote. It is in love that we are made, in love we disappear. Thank you. Right. Thank you. Think there'll be any more questions?
Thank you, Ross.
Thank you.
Thank you, Dr. Sallnow. There's no question from the web. Are there questions from the room? If not, we will close this session with profound gratitude for Dr. Sallnow and Taylor, who came and shared very important work. The reflection and the conclusions and the thinking of the Commission are absolutely essential in 2022. And I challenge you to go and search on the web the full document and to read it, not at nighttime, but like, yeah, that's not particularly a bedside reading. But I think that like I was so thankful that you both accepted to come and present the conclusions of the Commission on the value of death. Thank you.
Thank you.